Hi guys, thank you for joining. We just need a minute to get set up. There's loads of people in like the rooms around. It's Medic's Panto and stuff, so we're just taking a little second, but we should be on in a minute. Okie dokes. I think we might have everyone online that we're going to have. So thank you so much for joining, guys. My name's Charlotte, for those of you who don't know me, and this is our collaboration between MedEd and Scalpel this year, where we're going through all the different surgical specialties that are relevant to the UK MLA. So we've already done general surgery with Parwaz, and then colorectal with Jasmine, and then last week Nikita and Beta came and did a really good session on opthal. And you've got me this week doing peds surgery, but next week you've got Amir and Harini coming and doing trauma and orthopedics. Then Humna's doing ENT, and then we're finishing up the semester with Tim doing vascular surgery. So we're trying to really focus on management, trying to keep things really relevant to what you actually need for your exams. So any questions, please do pop them in the chat throughout today, and I'll try and keep checking regularly. But we don't have anyone else online watching to check, so I might have to come to them at the end. But thank you so much for being here. So this is the kind of plan for the session. I think pediatric surgery is one that we don't get a lot of exposure to, even if you are on pediatrics. I know I unfortunately even missed my week where I was supposed to be rotating through surgery and pediatrics. So the experience I've had to get sort of through outside avenues. So just having a bit of a think and a discussion about what pediatric surgery actually encompasses. And then I do a lot of talking about neonatal surgery in particular. So much of these presentations can be linked back really logically to embryology and neonatal development. So it's good to just go over that. And then remembering that children present with symptoms, not diagnoses. So going through some key presenting complaints in pediatrics, how we manage those surgically. And then particularly because this is a collaboration with Scalpel and former president of Scalpel, Georgia, we were having a chat actually. She had primary bone cancer in her childhood, and we were talking about how little awareness there is about that condition. So just raising some awareness on that, signposting you to resources, and explaining why it's so important that we know the symptoms and recognize them in children. So starting off, that you'll see some MedEd graphics have snuck in. We like to pose questions that you don't necessarily have to answer, but just ones to make you think about and kind of challenge your own perception of different specialties. So what actually is pediatric surgery? So I'll give people a second to kind of consider that, what you actually think of pediatric surgery, what you think it covers. You can either pop it in chat or just think to yourselves, I don't mind. So pediatric surgery is essentially the only surgical specialty. You don't get any other specialty that's defined by age rather than a specific condition. So it covers all sorts of diseases, traumas, malformations from the fetal period all the way to teenagers. So it's a really dynamic specialty and quite demanding of the surgeons as well, because physiologically there's such a vast difference between a neonate, obviously, and an 18-year-old. So you have to have really specialist centres for this. And there's about 29 centres across the UK that are equipped with paediatric surgery. So those are either within a specialist children's hospital or a particular surgical unit within a larger hospital. So obviously we're in Manchester, we've got Royal Manchester Children's, you've got Alder Hey just across the way. So it's a really interesting specialty, really broad. And as you kind of approach into teenage years, you do start to see overlap with adult conditions. So a lot of what we're emphasizing today is very much early years pediatrics, but it's still really important. And I think it's kind of not even a no man's land, but when we learn about peds, we do a lot of the medical stuff, and surgery is a trickier area to get your head around. So when it comes to neonatal surgery, it's a really developing area, mostly because as technology improves, so too does our ability to catch things early and therefore treat them earlier. So surgical interventions have improved massively to kind of align with where we're at in terms of early diagnosis, because what's the point in telling two parents your child has this condition if you can't do anything about it? So there's lots of different interventions, and unfortunately my animations have betrayed me, where you can identify anomalies in a newborn baby. So you've obviously got the pregnancy journey itself, but then you have the neonatal period, which is counted as the first 28 days of life. So within pregnancy, you've obviously got your first trimester, which is your first 12 weeks of gestation. And typically it takes people a while to realize that they're pregnant. It's usually from a missed period, unless it's really regimented fertility treatments and regular testing. And then, of course, the big scan is the detailed anomaly scan. So you get that ideally around 20 weeks, but there tends to be a bit of flexibility. You know, ideal world, we'd get everybody spot on 20 weeks, but that's not how it happens. And then third trimester, you're just monitoring baby's growth, checking for any intra-uterine growth restrictions and any other abnormalities, for example, things like polyhydramnios, oligohydramnios, things like that. So when the baby's born, you obviously take an APGAR score, make sure that baby's well. Do they do their first cry? How does their skin look? How are they behaving? Are they moving all their limbs equally? And then, of course, you've got your NIPE exam. So some people call it NIPE. I've heard different things, but we'll go over it a bit later. First one is within 72 hours. And for those of you that have already rotated through GP, you'll probably have seen a lot of baby checks tend to happen out in the community, but you've also got them ideally between 6 to 8 weeks. I tended to see them more around 10 weeks, but you want to check baby just before you send mum home. And then when they're a little bit older, just check that everything's okay. So in terms of the detailed anomaly scan, there's about 11 different conditions that you look for. So I'll give people an opportunity. I just gave you a bit of a giveaway. To pop in chat any that you know of that we look for on the 20-week scan. Doesn't have to be surgical, but any condition you know that can be identified on that 20-week ultrasound. So fine if you don't put any as well, but it's just to give you an idea to like think of. So first one, I kind of like to take a top-to-toe approach. Anything with babies, just keep it logical, keep it simple, because they can't tell you anything. So as long as you have a sort of mental flowchart process you go through, they're logical little things. They cry because they're hungry. They cry because they're upset. They cry because they're too hot. Like they kick out because they're uncomfortable, or they'll pull away at their nappy because they've soiled. Like there's so many different things that babies do that are just completely logical when you just kind of look at their behavior, and it's the same when you're trying to diagnose them. So on an ultrasound, first thing you do, just look at baby's head. So there's the first one called anencephaly, and I'm going to go through all of these in a lot of depth. And then along the similar lines is thinking about CNS development. You can have an open spina bifida. You can see that on ultrasound scans. And you can get severe skeletal dysplasia as well. So that's kind of abnormal bone development. And then, of course, you've got your cleft lips and cleft palates. Those are quite challenging to see, but if you've ever been in those specialist radiology sessions where they're looking over the ultrasound scans, they do them so routinely. They can spot even the most minor changes. It's really, really impressive. And then you've got, of course, congenital heart defects. I feel like we do these to death in pediatrics, diaphragmatic hernias. And then there's these conditions, also called omphalocele, ex-omphalus, whatever, gastroschisis, bilateral renal agenesis, and then you've got your Patals and your Edwards. When we think about scans, we usually think about checking, nuchal translucency, alpha-fetoprotein, and Down syndrome. But these 11 are actually the key ones. And there's great resources online for expecting parents that they can go and look over all of these before their scans so they can come with any questions. And particularly if you want to go into sort of like obs and gynae, if you want to go into pediatrics, I think knowing the resources that are out there for the parents is just really valuable because they're at the center of this. This is their journey that we're helping facilitate and guiding them through all of this. And if they're about to find out that their child has one of these conditions, understanding what's out there for them that they can go and read again, but also preparing them beforehand if you have a high suspicion of one of these. So just having a look. NHS has some really good ones. Okay, so starting with anencephaly and open spina bifida. So I have a bit of a specific interest in these just because I did some research on hydrocephalus before. I feel like we kind of touch upon it when we're in like year 2, semester 3, and then we kind of just wave it goodbye and never really talk about it again. And it's like maybe a QuesMed question. But other than that, what actually do we do with it? So anencephaly, I'm not sure if any of you have heard of it before, but anencephaly essentially refers to when you don't have the top part of your skull. So you also don't get development of the forebrain properly, but this all comes back to how your CNS develops. It's your neural tube formation, your neural plate, your neural tube closure. So both anencephaly and open spina bifida are put together because they're that same physiological process, that same part of embryology. It's all about folate metabolism, and this is why we really encourage mothers to folate load before they conceive, because this is so, so early in fetal development. And it's such a sad fact, but in anencephaly, it's not actually compatible with life. So these parents will have this new excitement and be so excited for this new baby, but even though we can diagnose anencephaly at 20 weeks. That's 5 months of a woman's life where she's been developing this baby and forming that attachment to it. And that baby won't survive. So it doesn't matter how much they love their child. It's just not something that we currently have any treatments for, any solutions for. So spina bifida, on the other hand, thankfully, these children can often grow up to have completely normal functioning, or we have decent MDTs and physiotherapy options that they can go on to live a normal, happy, healthy childhood. But anencephaly is a very different story. So just to recap your sort of neural tube and what's going on in that situation. So around day 18, you get your neural plates, and that's when you get your appearance of this little circle thing called your notochord. And it secretes all of these different growth hormones, which essentially encourage your ectoderm to become neuroectoderm. And that's when you get your neural crest and such. So you can see on the left-hand side of the screen, you've got your neural folds. Those come around, those create a neural crest. And then those neural crest cells, together with your notochord and all of these different growth factors, like I don't know if you remember Sonic Hedgehog and stuff like that, encourage the development of the neural tube. And then you can see in, I was about to say paragraph D, part D, you can see where the body cavity develops within. And you close your neural tube from cranial to caudal. So you do it from top to toe. So that's why we tend to get those sort of spina bifida problems a bit lower down, because it's that sort of slow process and they tend to get a bit of pocketing somewhere along where things just haven't quite closed correctly. So within your neural tube, you have to have subsections because we don't just have one massive long flowing system. We have a forebrain, we have a midbrain and a hindbrain, and then we obviously have the spinal cord. So your telencephalon is the key one that doesn't develop properly in anencephaly. So they've marked all of these different closures because this is how baby looks in utero. And errors in different numbers of those closures cause different defects, but the main ones we're talking about are anencephaly and open spina bifida. So you can see that when you don't have that proper closure at the caudal end, that's when you get your spina bifida. But when your telencephalon's not formed properly, that's your anencephaly. So this really emphasizes the importance of counseling women early in conception. Make sure they're having their folate. Even 6 months before conception is a good idea. The UK government has actually started folate loading. I think that was like 5 years ago. They started putting folate into things like bread products because it's so good for general population, and it's also got suggestions in conditions like Alzheimer's as well. Folate is great. We should be encouraging more people to take it, but particularly pregnancy, because these things can happen so early on. Okay, so with spina bifida, that encompasses spina bifida occulta, but it also encompasses meningocele and also myelomeningocele. So these diagrams are really good. Spina bifida occulta is pretty asymptomatic. It just means the vertebrae haven't completely closed, but your meninges are still nice and covered, your CSF is still nice and protected, and it's not really too much of an issue. You might identify it on an IP when you get that little tuft of hair at the base of the spine. And that's really why it's important to check between the buttocks, because it kind of just likes to go in that little tiny dimple there. But otherwise, they're okay. But then meningocele and myelomeningocele. So meningocele is when you get a little pocket filled with CSF, but myelomeningocele is a really problematic one because your spinal cord goes in with it. So protrusion of just the CSF is a bit concerning because obviously there's increased risk of infection, and we know we hate when CSF gets infected, meningitis and such. But their spinal cord is actually contained in that myelomeningocele. So it's a really worrying one. Okie dokes. So worrying thing with this as well is you can have an association with buildup and hydrocephalus. So this is a really large part of the sort of pediatric surgery work burden, is insertion of ventricular shunts. So you need to drain that fluid off. You've basically got this excess accumulation of fluid. You've pocketed down at the bottom with your myelomeningocele, which is threatening your nerve function. But then up the top, you can also have various obstructions that cause a buildup of CSF that compresses the brain. So anybody know anything about Chiari malformation? So fine if nobody does. Also called Arnold Chiari. So you basically get this downward displacement of, oh, we got someone in the chat, yay. I love when people ask. Seen an audit in ICU with it. Amazing. This counts. We love that. So Arnold Chiari type 2 is essentially where you get this down pressure being placed, so your spinal cord is also displaced down. But the main problem is, I don't know if you can see in this diagram, but you actually have your cerebellum is being pushed down through your foramen magnum, and that's really life-threatening. And it's one of those things that we also try and prevent when we're doing any kind of problems of cerebral edema, things like that, like management of hyponatremias in adults. We really worry about any kind of herniation of the brain down through the foramen magnum because you don't want compression of your brain stem. That's life-threatening. So in these children, because they've kind of developed Arnold Chiari, it's not life-threatening at that point, but you need to get it resolved ASAP. With hydrocephalus, you tend to get really, really large head circumference, but it is compatible with life, but you need to get a VP shunt in as soon as possible because you can get neurological dysfunction. So in terms of myelomeningocele, which is the one that we're thinking about for identification on ultrasound, what kind of problems do you think we're worried about with those people? So main thing is it's not dissimilar from when we sort of do like red flag history of back pain in adults. You're worried about the loss of function that comes from nerve compression. So you've got your motor side, they're going to have paralysis and weakness, but then you've also got your sensory loss anywhere below the defect. You're going to get that neurogenic dysfunction of the bladder and bowel, similar to how we do with like cauda equina. And then also they tend to have these orthopedic problems of they get scoliosis because of the abnormal spinal development, but also a club foot. So orthopedics tend to be involved in that process as well. So you're going to have a really multidisciplinary approach because you've got the neurology side wanting to make sure that motor sensory is fine, but then any kind of bladder problems, neurogenic dysfunction, you actually get some neurology input, and then orthopedics as well. So full troop comes in with pediatrics, and you have a lot of different options for when you can intervene. But the really big one, because we can identify this so early, is prenatal intervention. So you can actually operate and repair spina bifida whilst baby is still in utero. So that's really cool. And this is what it looks like. So you essentially have a hole, you have stuff herniating through. So you really want to carefully pop it back in, sew it back up, allow baby to continue developing, and then they're usually safe for a normal delivery. And what's really fascinating is that they've compared this study. So this is just another view of the surgery. They've compared outcomes in babies that were operated on. I don't know why this says prenatally. You can't operate on a baby prenatal, antenatally, compared to operations in the postnatal period. And there was no difference in outcomes. So the trial showed that it doesn't matter if you do it while still pregnant or afterwards, babies still do pretty much the same. And in fact, they had less severe Chiari malformations if they did have that association. They had less need for a hydrocephalus shunt, and they also had really good leg function. And I think the study was still ongoing. I didn't see any follow-up about bladder function, but that's a really exciting outcome. And as I was saying before, technology is catching up with diagnosis. So yeah, next one, going on to cleft lip and palate. So apparently I just got my diagrams all in a muddle because I had this all very nicely ordered and the other ones were meant to disappear and it was supposed to isolate cleft palate, but never mind, alas. So cleft lip and palate is more often than not being identified in the antenatal period as well. And what's really great about that is you get that input and that preparation of the parents before baby's even here, because there's a lot of things that you have to do to look after baby, make sure that they're meeting their nutritional requirements as soon as they're born. So you can really start priming parents for that, introducing them to the team, specialist nurses, the surgeons, any kind of dietitian input that they're going to have before baby's here. So there's different types of cleft. So an orofacial cleft essentially means an abnormal opening, and that's secondary to developmental failure in utero. So it doesn't have to be both lip and palate. It doesn't have to be both together. So when it comes to lip cleft, that's because the nasal and maxillary prominences haven't fused properly. Whereas with the palate, it's because the primary/hard palate and secondary haven't fused properly. So that's around weeks 5 to 12, whereas with the lip, it's more weeks 5 to 6. So you can get abnormal fusion at the front, and then that's kind of worsened later on. But it can be unilateral, it can be bilateral, and it tends to be visible at 20 weeks. As I was saying earlier, you need that sort of specialist team-based approach. So the radiographer will identify it. And there's a lot of different cases where it's associated with this really specialist thing called Pierre-Robin sequence. It's like 90% of that genetic syndrome presents with cleft palate, but it can also be entirely distinct, but you need to get a specialist within 24 hours. So you need to also consider about the child's airway. So if you've got failure of that formation in the palate area, your palate and all the formation of your sort of jaw skull area is really important to maintaining a patent airway in a child. You also need to consider in their long term, what about the development of their hearing, feeding, of course, but then also like dental, psychological, all of those really important aspects, because it's not just, I've got a baby that's been born with a hole here. It's, okay, this is my first baby or my second baby or my third. Everything's completely different than how I expected. No one gives you a clear guide on how to do this because it's not that common for people to have this for their babies. My support network doesn't know what to do. And it's really difficult for the family to adapt to. So there's a lot of different teams around the country that can help with this. So this is again related to folate. So just to check in the chat, what would be risk factors? We've talked about spina bifida, neural tube closure. We've talked about cleft palate. If you met a woman who wanted prenatal counselling, what would prompt you to put her on a higher dose of folic acid? Like what kind of risk factors? And also what dose? Yay, someone said something. Yeah, so absorption issues, but I'm thinking more like in the like booking appointment. Who's going to be put on the high dose folic acid? Yeah, so anyone taking anticonvulsants, definitely. Anti-epileptics, anyone with epilepsy, high risk. But you've also got your ladies who are diabetic. You're also thinking about anybody who's got a really high BMI. Any of these ladies are sort of a higher risk profile for not taking their folate in properly. So you can usually give it to anyone who takes the standard Pregnicare, 400 micrograms. But higher risk ladies, you give them 5 milligrams and make sure that they're taking that right up through their first trimester. Because we showed before with neural tube that was up until sort of 12 weeks, but it all happens even within week 3. And then with this as well, it's week 5 to 12. That's when you're getting that really important closure of your hard and soft palate that will potentially evolve into a cleft if you don't have enough folate present. So in terms of surgical, you have an abnormal opening, you want to close it. When it comes to lip, you want the child to be at least 3 months or older. And it's a 1 to 2 hour surgery, requires general anesthetic. They will have an overnight stay. Whereas with palate, it tends to be more like 6 to 12, I think it's 6 to 12 weeks or 6 to 12 months. 6 to 12 months, I think, where you have a palatoplasty and you need to help them with their speech and language development. They're a bit older, they'll start trying to form sounds and things. So you want to aim to correct any defect and reattach the soft palate. And again, quite an invasive procedure, general anesthetic, prepare the parents for the fact the child's going to have an overnight stay in hospital. And there's a lot of different combinations this can happen in. The diagram just shows that it can be uni or bilateral. But cleft lip, with or without palate, is twice as common as isolated cleft palate, just by the nature of the sequence of events. So lip closure is a lot earlier on than palate. So it's abnormal for your lip to develop fine, and then for some reason your fusion later on gets worse. Whereas it's much more common to see, okay, problem with the lip, but the rest happens fine downstream. Or, oh, lip's not formed properly, palate as well. So palate by itself is quite unusual. So any questions on anything we've covered so far? If I'm going too fast, just say. If I'm going too slow and you're like, Charlotte, hurry up, I want to go to bed, do say. Yay, no complaints. Thanks, guys. Alrighty, Rue. Diagrams. Please work with me this time. Okay. This is just a bit better. So next one we talked about was congenital diaphragmatic hernias. So this diagram is from Duke University, and it's really, really nifty-tifty. So it... I had one news. Oh, you are welcome. So It's typically you get a left-sided defect. So any kind of opening in the diaphragm, you have this risk of the abdominal contents being pushed upwards into the thorax. And it's really common that that happens on the left-hand side. So this diagram shows really nicely that you get your intestines moving up through into the left side of the thorax, compressing that left lung across, moving your heart position. And underneath, you can also end up with a bit of your liver poking through as well. So that's actually quite an advanced issue. So depending on the size of the defect will depend how much of your liver protrudes through. And you can do the correction via a thoracoscopic procedure, where you can either just close the defect, you kind of poke the contents back through and then just close it surgically, or you might actually have to use a patch. So there's a variety of patches. There's like, we'll talk about patching later actually, because this is more for when you're doing abdominal closures, but you can have different levels of rigidity. But the main thing as juniors that we would need to worry about is post-operatively, their lungs are going to re-expand. So they've got this abdominal contents that just come up and now it's gone back down, but you've had a lung that's been compressed this way all this time that now needs to have chance to re-expand. So it's really important to consider post-operative ventilation, and the duration that the child is on that is really going to depend upon the severity of their lung. I don't want to say collapse, but immaturity. So that will affect their overall outcomes, their duration in hospital, how long they're on ventilation, and therefore risk of infections, post-operative management. And of course, with all of these, you need to be considering any kind of fluid balancing. So you give a lot of IV fluids in these babies, and particularly in this next case that we're going to discuss. So again, thinking about GI tract, you've got gastroschisis and exomphalos. So main difference between the two, gastroschisis is you have bowels outside, but with no covering. And then exomphalos, you have bowels outside, but with a nice little covering of amniotic sac. Scalpel Manchester, is it something? Oh, they've just sent me the feedback form for you guys. So the difference between these two is the presence or absence of an amniotic sac just covering the bowels, but you're still going to get a lot of fluid loss in these kids. So this is just a nice way to remember it, because they usually call exomphalos and omphalocele. You can kind of remember that it's all contained within the little o, whereas with gastroschisis, it's kind of poking its way out of the G. I just thought that was quite a nice thing. So it does make sense why this happens. And again, it's very early on in fetal development. So you have that embryological process where your GI tract is developing and it's all outside of the abdominal wall. And then you get the sort of twisting in upon itself and then poking back through into the abdomen. So if there's any problem with that sort of retraction, you end up with all the bowel contents outside. And it might start to partially do it, but then you just get a covering and it doesn't fully successfully go back into the abdomen, or it stays outside completely exposed. And if you think about where all of your fluid reabsorption happens from, your colon, that's really problematic, especially when baby's born and you need to do a lot of fluid resuscitation and replacement and make sure that their nutritional needs are being met. So in terms of what we do to repair it, you have a child with their bowels outside of their body. Ideal circumstances, they're born, we can poke them back in and close. But if they've been in that state for a long time, you have the risk that the bowel is really inflamed and you might need time before that's possible, particularly in the case of large defects. So small omphaloceles are quite simple and you can usually just poke things back in and do a closure. But if you've got a large one, you have to construct this thing called a silo, which is essentially like a little baggie. You put the bowels in a little bag and you kind of pull them away from the body and you kind of suspend them above baby and allow gravity to help draw them back into the abdomen whilst keeping them covered and protected. And hopefully at the same time, you've got your IV fluid replacements going, your nutrition, usually some form of feeding going on. And also in the case of gastroschisis, so this is just showing it on a little baby diagram, which is all very cute. You need to think about the fact that hypothermia is just as life-threatening as any other problem. So you need to keep baby warm. So you need to keep them under a little ambient heater, and also consider if they could be in respiratory distress. So it's the same as with diaphragmatic hernias. Once you're popping all of this contents back into the lungs, you really need to monitor baby for increased work of breathing, off of ventilation. And if they've had a really severe case of gastroschisis, you may have to do gastric decompression or endotracheal intubation to basically help the lungs cope with all of these new changes in pressure that are coming from below the diaphragm, just as was the case with diaphragmatic hernias. So any questions on that? Nope. Groovy. Okay. Thanks, Lily. So, congenital heart defects. We love a congenital heart defect, especially at Manchester. This is like the big one. So I think this is a good time for us to just like go over the newborn and infant physical examination. I was so silly and I used to think this was neonatal, but I would then get confused. Why are we doing it after 6 to 8 weeks? They're not a neonate anymore. That's because it's newborn. So this is just what we talked about earlier, different opportunities for the NIPE, but nothing else really matters except the red flags. When you do these examinations, I don't know if anyone got to do them during their pediatrics placement, it's all very opportunistic. So while baby's eyes are still open, check the red reflex. Get it done as soon as possible. Stop worrying about the rest. Definitely do it before you put a cold stethoscope on their little chests. Just if they're looking at you, as soon as their eyes open, just ditch the other thing and do the red reflex. Because I don't know about you guys, I could not get those babies to look at me. They'd have their eyes just about open, but their little eyelids were drooping. As soon as those eyes were open and they were curious, getting some red reflexes. So any absence of that red reflex, get them to ophthalmology as soon as possible, because it can either be, if they're premature, you've got sort of the retinopathies, but it's more likely it's possibly like retinoblastoma, which is rare, but get it sorted. Any murmurs, make sure they get an echo. And big one is if they don't have dissension of the testes by the second IP, refer them to a pediatrician. Differs who manages it by local referral pathways, but just get them referred. And then, of course, if you can dislocate their hips on the Barlow-Ortolani tests, get them a hip ultrasound scan. That's the main things from the newborn and infant physical exam. We can go through all of the different bits and bobs that you have to look at on the top to toe exam, but I think they're pretty intuitive. Like check the fontanelles, check generally over the skull, keep moving down the spine, have a check. Are there any tufts? Check they've got like patent anus, things like that. It's very much a top to toe. And just when you go through, genuinely look at all the different parts of a baby that have developed and check they're fine. We can go through that. If no one puts it in the chat, they want us to go through that though, I will not be. Okay. I'm taking that as a no. We love that. This is great news. So this is just a summary, and it was a lovely animation situation. I don't know why my animations have not worked, but this is just a summary that you've probably done to death of congenital heart defects. It's really not complicated. Pediatric surgery is super logical. Just think about which component of the cardiac cycle will be affected by this opening. Therefore, when will I hear a murmur? Where does that opening sit? Therefore, where will I be able to hear it best in a newborn chest? And then when I want to repair it, there is specialist repairs for each of those defects. It's very specialist, cardiothoracic pediatric surgeons. They have their niche. At Royal Manchester Children's, they tend to go sort of by area of the body. So they go like, I do stuff above the diaphragm. These guys do stuff below the diaphragm, but different hospitals differ in how they do things. But I just remember being on the below the diaphragm team, and when I went into theatre, they gave me jelly babies. So that's maybe biased me. But yeah, congenital heart defects, they get repaired. So now we'll move on to sort of key presenting complaints. And when it comes to heart defects, ideally, we've picked it up on an IP exam, done the echoes, found it, referred to surgery if necessary. But that's not always the case. Some of them creep their way into adulthood and they've just not been picked up. And the way that they tend to present is with this idea of failure to thrive. It used to be called faltering growth, but that's more of a description, not a diagnosis. Failure to thrive is considered a diagnosis. So it's normal for babies to lose 10% of their birth weight, but you consider them faltering if they drop off 2 or more centiles. So they can have catch-up growth, where they're a small baby that starts to catch up to their centiles. You can have catch down, whereas larger babies, they were quite big, and then they normalize to sensible centile. So when you take the history, you have to think about like, how was this baby fed? How old were they when they were weaned? And what foods are they now taking? What are their mealtime routines? Maybe consider even like a food diary. Ask the mum about antenatal history. Were they preterm? Any intrauterine growth restriction? Is the child now well? And then you can kind of do a full examination. But in terms of limiting it down for surgical relevance, there's sort of 4 aspects you can consider in failure to thrive and try and think about where might there be a surgical complaint. So first part is inadequate retention. Or do they have an increased requirement? Are they just not absorbing any nutrients they're getting? Or are they just failing to utilize any nutrients that they're taking in? So I'll give you guys a second to think about those 4 domains and what different presenting complaints might fall under those. Because of course you've got inadequate intake as well, but these are kind of the 4 that we don't necessarily think about. Okay, so starting with inadequate retention, that's your classic, I'm taking it in, but it's not getting where it needs to go. So you've got your gastroesophageal reflux disease, or you have an allergy to cow's milk protein. So in all of those kids, this isn't a surgical complaint, but they're not retaining any of the nutrients they're getting in. However, congenital heart defects actually fall under an increased requirement. So there's an increased demand on baby's body or on the little one's body that means that they're getting in normal amounts of nutrients seemingly for a child of their age and their size, but they've got this system problem that's demanding they take in even more. So that can also be their thyroid is super overactive. It can be cystic fibrosis where they're getting this excessive mucus production and they're just not having that same functionality as they would have. Malignancy is a big one. Malignancy is all about supply and demand. That's why our patients become cachexic even into adulthood. And those are the big questions. And your fevers and your night sweats, it's all about supply and demand being thrown off whack. You can also get chronic kidney disease, chronic infections such as HIV. Malabsorption, again, is like your celiac disease, your cystic fibrosis, liver problems, anything with your gut. And then, of course, you've got your failure to utilize. So that can be genetics, that can be prematurity, that can be congenital infections. But I just thought if we're going to mention congenital heart disease, think about how they might present. That's not just a perfect murmur. So any of these conditions could cause a failure to thrive, but it should mean if you see a child that's not growing properly, consider, hang on a minute, could this be a congenital heart defect? So I got caught out with that when I was actually seeing a child. I was talking to my GP about it and he told me a story of when he had a child come in, they had no murmur, but they still had an underlying heart defect. And then they had all of this fluid accumulation and he just had a niggling sense in the back of his mind that there was something off that meant that this child wasn't meeting their sort of expected milestones. And it turned out to be a heart defect. So it's not always a murmur. Okay, so vomiting in children. I think everybody on this call is a manc. So mumps will be covering this next Tuesday. We'll be doing the session gynecology first and then sort of gastro and fevers in children next week. But when it comes to vomiting, there's so many different ways a kid can vomit and kids just love to vomit. It's like their best way of saying, I'm actually sick. So you can have medical causes and you can have surgical causes. So I think it's really good to consider differentials and actually just isolate vomiting by itself, where it's not that perfect pass med question that's already said this child is vomiting in this very characteristic way, because parents are just going to bring in their kid and say they're vomiting. So give you a second to think of all of the different medical versus surgical causes of vomiting that you know. Okay, so hopefully you've had a bit of a think to yourselves of, okay, how many do I actually know? Because I remember being presented with this as like a practice history to do in a sort of OSCE practice with friends, and I was like, oh God, I hate vomiting because there's so many things it could be. So in terms of medical, there's so many. So you've obviously got like, okay, a feed baby, and then they do this funny back arching thing, and you've got your refluxing. But then you've also got like the forceful vomit. So there's so many things that cause a kid to forcefully vomit. So it could be everything's really inflamed down below and they just want it out. So that's like a gastroenteritis. But it could also be they're just generally unwell and they've got a pneumonia. They've got like all of these other resp effort distress symptoms, and they're forcefully vomiting as well because they just feel rotten. And you can usually tell your warning signs like less wet nappies, not opening their bowels as often, decreased oral intake, but they can also forcefully vomit. So same thing with like ear infections. They're just feeling rotten. They've got pain in their ears, pulling on their ears, losing their hearing, and then your meningitis as well. So forcefully vomiting, and of course, check if they've got a stiff neck. Kids aren't going to tell you they've got a headache. They're just going to be a little tyrant. I saw a 6-year-old and she was so sweet, but she was just completely shut down. She's just not herself, really withdrawn, and she had an upper respiratory tract infection. That was what we identified, but she wasn't telling us what was going on. You literally just have to be a detective and try and figure out, okay, they're not themselves, but why? And if they're sitting really, really still and they're not moving their neck, suspect meningitis until proven otherwise. The worst you can be is wrong, but safe. Just assume it's meningitis until proven otherwise. So then you've got your sort of less sinister ones like your tonsillitises. And again, with UTIs, really non-specific fever in a kid, they love to get just a fever and a raging urinary tract infection. So there's very specific guidelines for when you refer and you think of what counts as recurrent and what counts as typical versus atypical. But fever's the key thing. They can also vomit though. And then with your whooping cough, lots and lots of coughing, and then suddenly they vomit. If there's older children though, DKA. So really possible way that they can present with first presentation of type 1 diabetes mellitus, they can present with a DKA. But also if they're a bit older, think of things like bulimia, and even consider pregnancy, need to take a decent sexual history if they're of a certain age. Also consider illicit substance use, drinking, things like that. So don't limit your diagnoses by what you think you know of this child. Still keep that broad differential list because anything is possible. Now we move on to the surgical ones, which is what you're here for. So your classic one is your pyloric stenosis. They love a bit of projectile vomiting. And when they say projectile, it's literally like, I was told this when I was on Paediatrics. They were like, if you were stood on that side of the room, that vomit would reach you. That's how projectile it is, which is very logical. The way that your GI tract works, if any of you came to our session a few weeks ago, particularly when it's about forcing things down from the stomach, it's a very strong contractile process. You've got all those rugae within your stomach that can force a food bolus through, and it's a lot of churning out. If you've got this constant pressure, that means all of that is just building up in one continuous chamber. When that is eventually released back up the esophagus, is going to be a very strong projectile force. So that's why it can reach quite so far. And you can usually palpate something on the abdomen, but I've never personally felt one. There was a kid who had a pyloric stenosis, but bless, was not in the mood to get examined. Then, of course, you've got your GI obstructions. You'll get quite a bilious type of vomit, maybe a distended tummy because they can't get anything through, appendicitis. And then there's your more abnormal ones, like a testicular torsion and brain tumors. So when it comes to testicular torsion, we really don't cover much. We do a whole specific section on like women's health, but we never do anything on sort of specific like urological testicular torsion presenting complaints. I don't know when we've ever done something on that. It's one you have to kind of go out and think about, but particularly in kids, consider testicular torsion because it's really possible in those early days of life, like straight after birth. And particularly when testes are still undescended, kids are really prone to it. So consider a testicular torsion. There's a critical window of 6 hours where you need to be trying to preserve that tissue because otherwise it can make the testes completely non-viable and you end up with a child with a necrosed testis and you literally have to resect it and try and fix the other one in place. And that's really early on in their lives and that will affect their fertility going forward. And it's really time critical situation. And then brain tumors, of course, don't miss them. They're most common type of malignancy, most common solid tumor type in children. And look for your neurological signs, your symptoms of a raised intracranial pressure, so your headache, your blurring of your vision. And they tend to sort of localize around the cerebellar area. So they get a lot of loss of balance and they're going to be groggy with a change in their behavior as well. So just thinking logically about each of these conditions, when it comes to the surgical management, I love pediatric surgery because it just makes so much easy sense. Pyloric stenosis, I've got thickening of my circular and my longitudinal muscles. So what am I going to do? I'm going to separate them out. I'm going to do a pyloromyotomy and literally separate the two back out. Makes perfect sense. Problem solved. Thickened area closed off. Let me open it back up. Now, your GI obstructions, it's a similar story. There's a lot of different reasons that you can have a GI obstruction in a child. So, big one is you've got things like your Hirschsprungs. So, Hirschsprungs is where you have an area of the bowel that doesn't have any nerve cells, so you don't have your ganglion cells. That's why it's also called intestinal aganglionosis, and it's blocked. So tends to present when the kids aren't passing their meconium within those sort of first 12 to 48, 24 hours. And it's repaired via something called a pull procedure. But they tell us this in the question banks as if every child comes in and it's, oh, they've not passed meconium, Hirschsprungs, easy. I saw an 8-year-old with Hirschsprungs and he was adorable. He was playing with trains, but he was a naughty little thing. He kept running and like hiding under the bed. And then he had to be asked about his number 2s, but he had Hirschsprungs and he needed a pull procedure. So they're not always so cut and dry like failure of meconium. Still consider this in your differentials. So this is more of a sort of general overview summary. So you've got your meconium ileus, you've got your meconium plug, of course your Hirschsprungs like we just talked about, but also in that process of bowel formation, when you're in your embryological development, it's all happening outside and then pokes back in. All of that twisting and turning though, as you continue to develop, you can get a volvulus. And of course, on your 9P, make sure you check that they have a perforate anus. If you don't do a proper check between, you could miss an imperforate anus and then you could end up with a child with a GI obstruction, which would be really problematic later on. But one that comes up a lot is atresias. So we talk about biliary atresia. Neonatal jaundice is quite common. We had a station on it in our CCAs, but there's lots of other atresias as well. So I've seen babies with tracheoesophageal fistulae, and also you get esophageal atresia, you get duodenal atresia, and you get large bowel atresia as well. I'll give you 2 guesses what you do in a case of an atresia. Again, really nice and logical. You take out the atresed section, you join the other 2 bits together. It's very logical, very sensible. I've put this diagram on the left-hand side though with the different atresias and fistulae because there's lots of different types, depends where the fistula is, how you do the repair. That's quite a complex process though, that's not relevant at this stage. If you're interested, I will find some full papers and I would be more than happy to send them to you if you just pop that in the feedback form. Okay, so then we talked about testicular torsion. So when it comes to testicular torsion, you essentially get twisting around the spermatic cord due to inadequate tissue attachment. You end up with impaired blood flow and you have that critical time frame. Time means tissue of 6 hours. More than 24 hours, you're almost like guaranteed it's necrosed, it's non-viable, it's gone. So your spermatic cord starts at your deep inguinal ring and then enters into the scrotum at your superficial. So soon after birth, or sort of around puberty time when you've got like dissension of the testes, you've got possibility of a torsion. So it can happen inside or outside of the scrotum. And key thing is to consider the twist scoring system. So if you've got a child with a hard testis, any swelling, nausea and vomiting is a key one. Absent sort of protective reflex, if you poke them in their inner medial thigh or sort of gently stimulate that area, they should have ascension. If they don't, that reflex is absent, consider a possible torsion. It's like a protective thing. And if it's high riding as well, that's also a possible sign of testicular torsion. And I wanted to show at this point this really cool flow chart for this, because next thing is acute appendicitis, which Pawa's already covered before. So this is a really brilliant case note summary that goes through everything on testicular torsion. So this is looking at intravaginal, which is where it's sort of within the scrotum, and it talks about this thing called a bell clapper deformity, which a lot of men can have. And it basically just means they've got a lot more room in their scrotum, so they're more prone to possible torsions. So this is just going over that presentation, covers the twist score as well, and it shows what you might find on a physical examination, because it's primarily clinical diagnosis. They mention ultrasound here, but don't faff around with trying to find an ultrasound. Get their referral going. So viability within 4 to 6 hours, 97 to 100%, great, solved. Any more than 12 hours, you're dropping right down to a possible 20 to 61%. More than 24 hours, 0 to 14% are going to be viable. So you really, really need to get an early surgical consultation. If you're still viable, the key thing is you untwist and fix. So you don't want this to happen again, because they're always prone to possible retorting. So you want to fix them in place in a procedure known as an orchiopexy. But if it's not viable, you have to do an orchiectomy. So on the other side, to where it's not torted, you want to then do an exploration, and to prevent that happening on the other side, you also fix the other testes in place. So it takes about 1 to 2 weeks for them to recover. And you can have normal fertility going forward if you do lose one of your testes early on, but still, it's not something that you want to be putting men through in their future if you can avoid it. So remember those critical time frames of 6 hours and act quickly. So Pawa's was absolutely brilliant. I don't know if you guys caught the general surgery session, but I learned so much from him. He's president, I'm pretty sure, of General Surgery Society. So this is his sort of passion area. And he made these brilliant slides covering appendicitis, explaining about how it's hyperplasia of a fecalith, and you end up with these sort of gut organisms invading into the appendix, and then you get this edema, ischemia, and possible perforation. So these are all of his slides, and you can get the recording on the Scalpel website, but he goes through it way better than I could. So these are Pawa's slides, and then he went through the management and how it differs depending on if you think it's simple versus complicated, if you think there's a perforation, or in the case of an appendiceal mass. So he goes through that really thoroughly on the recording. I just wanted to give you access to these slides now as well. But here's the cool bit that's more of my interest area. So pediatric brain tumors. I found this from a site called Ariella Studies. So I was going to try and do a brain diagram and talk about the different areas where brain tumors develop, but I just think this is such a great visual aid. And I don't know who drew it, who Ariella Studies is, but this is just brilliant. And I think if you look through all of them, they're just so good at summarizing because with all of these, you have the risk of hydrocephalus. So we talked earlier about when it might develop in very early years, but you have two different types of hydrocephalus. So you have obstructive and communicating. So obstructive is when you've got a blockage of the CSF flow. So it's typically you get problems in there's your foramen of Monro, your fourth ventricle, or your cerebral aqueduct. So you can get a tumor in the fourth ventricle. But also if you look at the top here, you can get a tumor from your pineal gland. And that's one that can cause compression of the cerebral aqueduct itself. So usually it's just from stenosis, but this rare type of tumor can also compress and cause hydrocephalus. So then on top of that, you've also got, if you look down in the bottom left-hand corner, you've got the ependymomas, which develop from the actual ventricles themselves. So again, you could get possible hydrocephalus because you've got changes to the actual cells that are lining your ventricles. That's where all your CSF flows through. So I just think it's a really brilliant diagram and it nicely covers the different signs. So the rosettes, they love a rosette. So you get a perivascular rosette if it's your ependymomas. You get your Horner Wright rosettes if it's a pinealoma. And then if it's a medulloblastoma, you get a Homer Wright rosette. So those are just random things. They're much more sort of USMLE, but they're these really characteristic signs you can see on histology. But the craziest thing about medulloblastoma is you get a non-communicating, again, obstructive hydrocephalus, but still you get what's called drop metastasis. So the brain tumor itself develops within its own area, but then because it's got access to the CSF, the metastatic cells can actually drop down and continue to travel, and you get these kind of drop down metastases. So I just thought that was really cool. But that's another differential to consider in a child with new vomiting. You've also got your more benign tumors like your craniopharyngiomas, but that's more endocrine type problems because you get that sort of compression of the pituitary gland. So that's part 3. Moving on to the last part, which is about sarcoma. So key question, what is sarcoma? I feel like we get told about sarcoma all the time, but what actually is sarcoma? Anyone? Okay, no takers. So sarcoma is essentially tumors that develop within the connective tissues. So the reason I'm talking about sarcoma is because of bone cancer. So bone cancer is not one that they really talk about when we're in pediatrics. And I think compressing pediatric teaching into 4 weeks is really tough as is. But bone cancer in particular, Bone Cancer Research Trust are really proactive in trying to increase awareness. And the reason that I'm bringing this up is because we get so much teaching on meningitis, and it actually has similar rates to primary bone cancers. So we learn so much about the recognition and prevention of meningitis, but we don't learn about primary bone cancers, even though they have similar incidence in the UK. So Bone Cancer Research Trust are trying to change that, and they have so many different infographics available. And this is a really nice summary of all the different symptoms of bone cancer, because a lot of the time you might see this kind of pain written off as growing pains. And I know that's particularly what Georgia went through, previous president of Scalpel, and she does a lot of work advocating for increased awareness and improved diagnostic procedures for bone cancer. So any child with an unexplained limp, refer on. Consider any kind of bone pain, take it seriously, have a high index of suspicion. If you're not absolutely certain this is not bone cancer, again, consider it until proven otherwise. Handle it the same way you do meningitis. It's the same incidence rate, so you still need to have that high index of suspicion for it. The main surgical procedure is limb sparing procedure. So just as we've done with the other parts, when there was a problem with the bowel, you take out the affected section and then rejoin. With limb sparing surgery, they'll go through it more with orthopedics and all of the clever stuff, which is very engineering and physicsy of orthopedics. where they use prosthetics. So you can see these are both images from Cancer Research UK. So they have a lot of stuff on their website explaining what will happen in surgical procedures. So you can see in the humerus, you have a small area of cancer, but they actually take a large section of bone all the way up to the joint and then insert a prosthesis. And then same thing, if you have a cancer within the tibia, you would then use a full prosthesis. You can maintain the fibula, but the prosthesis actually includes part of the femur as well. So again, just wanted to signpost to a super cool resource, which is the Bone Cancer Research Trust website. So they teach you about what sarcoma is, how it's a cancer of the connective tissue, gives a diagram to explain all of the different bones, how it's most likely going to happen in your long bones, peak incidence ages, so 10 to 25 years old. That's the key time where you're going to be telling people, oh, it's growing pains. You're going through your growth spurt. Have that suspicion, could it be bone cancer? Because if you look on the diagram I showed before, it's got those typical red flags. So if you look down here, they're really tired. They're getting fevers, they're losing weight, they're losing their muscle tone as well. Don't just attribute it to growing pains and growth spurts unless you're absolutely sure. So there's 4 different types. You've got your chondrosarcomas, osteosarcomas, Ewing sarcoma, and chordomas. And this is their relative incidence rates. And then you've got all of these other really rare ones of bones as well. But this is a brilliant summary resource, and particularly in terms of advocating for survivors of bone cancer. It's really good to know the resources that are out there so that you can share them with colleagues and also share them with future patients that you might meet, that you might be counseling one day, because you never know when you might meet somebody who's been diagnosed with a bone cancer, because you also never know when you might meet someone diagnosed with a meningitis. So just wanted to do that for Georgia because she really opened my eyes to this condition, and particularly when talking about pediatric surgery, the mainstay is surgical intervention. So I think it's really important to talk about for all of us when you guys clearly have an interest in pediatrics, and just a good one to be more aware of going forward into our careers. So thank you all so much for coming. There was a QR code on these slides. I don't think it's for the right session though. So please can you fill out the feedback form that's in the chat, and then any questions that anyone has, please feel free to pop them in. But if not, you guys know where to find me. You can either message me on WhatsApp or email manchestermeded@gmail.com, and that'll get sent to me from our secretary, and then I can answer your questions if you have any. But thank you so much for coming, guys. It's so nice to see you all on these calls. Thank you. All done. I don't know how I stop the recording. Okay, I'm just going to end the call. Thank you, guys.